Medtronic analyzed and tested SCS systems in an effort to provide best practice recommendations for implanting system components. Following are examples of the testing completed. Tensile forces on the leads and extensions of implanted SCS systems can cause axial lead migration. This migration can result from acute application of mechanical forces or through cyclic tensile loading causing progressive lead movement. The amount of tensile force on an anchor is a result of both body movement and the stiffness of the leads, extensions, and surrounding tissue. Medtronic estimates in vivo tensile forces on lead anchors by combining the amount of body movement from biomechanical analysis with measured lead, extension, and stiffness of surrounding tissues. Understanding these mechanical forces on anchors allowed the consensus group physicians to recommend anchoring techniques and implant configurations. Computer simulations of the spine, torso, and surrounding structures were used to determine the amount of displacement between structures in the body near anchor points of the SCS system. For example, a typical maximum displacement during twisting between the spinous process near the anchor location and the abdominal muscles near the neurostimulator location is about 1.9 centimeters. For comparison, 7.6 centimeters is the typical maximum displacement between the spine near the anchor and the iliac crest adjacent a buttock-placed neurostimulator when the spine is flexed. This is over 4 times greater than the amount of movement in the body affecting an SCS system with an abdominal neurostimulator implant. The overall stiffness of an implanted SCS system is a combination of the individual stiffnesses of the leads, extensions, and tissue surrounding the implant. Animal studies were used to determine the stiffness of tissue surrounding strain relief loops, anchor, and the neurostimulator. In one study, 5 sheep were implanted with neurostimulators and spinal cord stimulation leads. After 4 months, the stiffness of the lumbodorsal fascia and fibrotically encapsulated strain relief loops were measured. Medtronic engineers then analyzed the data to determine the spring rates or stiffness of the surrounding tissue. They found that the lowest spring rate, or lowest tissue stiffness, occurred at the subcutaneous tissue surrounding the lead strain relief loop. The stiffness of the leads and extensions were independently determined in the laboratory on tensile testing equipment. Tensile forces, or loads, exerted on the anchors were then calculated based on the expected body movements for various implant configurations and using the system stiffness of these implant configurations. When a neurostimulator is placed in the abdomen, the maximum tensile force is much less, at about 1/3 pound. This force may increase, however, if the neurostimulator is not sutured down and is allowed to rotate. Migration is further prevented by using a strain relief loop by the lead at the anchor site. Testing and analysis estimate that adding a strain relief loop can reduce force on an anchor as much as 40% or more. This is because the strain relief loop lowers the stiffness of the implanted system. Bench testing was performed to evaluate the attachment strength of various anchors to percutaneous leads. This testing was done quasi-statically using a tensile testing machine that applied a slow and controlled displacement rate while measuring the breakaway force. Of the anchor configurations tested, the configuration with silicone anchors using medical adhesive provided the highest attachment strengths, with average breakaway forces of typically more than 2 pounds. A cyclic test that applied a sinusoidal load was also used to evaluate anchor attachment strength. The silicone anchors using medical adhesive were also the most resistant to progressive slippage. Anchors in this configuration tested to over 1 million cycles at 0.75 pounds peak force without failure. Biomechanical analysis for the causes of longitudinal lead migration yielded the following conclusions. Use silicone anchors for percutaneous leads. Use silicone medical adhesive on anchors with percutaneous leads. Use strain relief loops. Use a figure-8 suture to prevent movement of the anchor in the tissue. Place the neurostimulator in the abdominal area rather than the buttock area whenever possible. In order to determine implant guidelines and techniques to reduce lead fractures, Medtronic analyzed the buckling, bending, and tensile forces to which stimulation leads can be exposed. Bench testing was performed that simulated the compressive loading imposed by the body on a 3890 Pisces Z-quad percutaneous lead when the spine is moved from flexion to extension. A specific length of lead was captured between two attachment points, one representing the anchor and the other representing the point where the lead enters the deep fascia. When the 2 points of attachment were moved toward each other, as occurs when the spine is extended, the lead was forced into a buckled state where the inside radius of the bend was 1/2 millimeter. The 2 points were then moved apart to the original positions, constituting one loading cycle. This accelerated test produced fractured lead wires at an average of 5,500 cycles. The fatigue test was repeated to simulate the use of a silicone anchor protruding through the deep fascia and preventing the lead from kinking. In this test, the inside bend radius of the lead in the buckled state was 1.5 millimeters, and the number of cycles to failure increased to more than 300,000 cycles. Bench testing was performed to simulate the loading imposed by the body on a surgical lead at the location where the lead body attaches to the electrode paddle. 2 configurations were tested. The first, with loading equivalent to when an anchor is located on the lead body at the point of attachment to the deep fascia, and the second, with loading equal to the use of a strain relief loop in place of the anchor. In both configurations, tensile loading cycled from 0 to the maximum value sinusoidally until a failure of a conductor was detected. The surgical leads failed at an average of 16,000 cycles when simulating the use of an anchor. When simulating the use of a strain relief loop and no anchor, the surgical leads were tested to over 1 million cycles without failure. Biomechanical testing for the causes of lead fractures yielded the following conclusions. Do not use anchors for surgical leads. Support percutaneous leads by pushing the tip of the silicone anchor through the lumbodorsal fascia and use a figure-8 suture to minimize tissue trauma. For surgical paddle leads, use strain relief loops in the epiphyseal plane.